Welcome to the National Faculty Meeting. As the Chair of the Board of Directors of AACN, it is my great pleasure to welcome you to AACN's first National Faculty Meeting. This convening at your School of Nursing is a critical step to ensuring that we hear from a wide cross-section of our membership and benefit from the best thinking when it comes to re-envisioning AACN's essential documents. As you likely know, the AACN's Essentials outline the necessary curriculum content and the expected competencies of graduates from baccalaureate, master's, and Doctor of Nursing practice programs, as well as the clinical support needed to ensure quality nursing education. The reconceptualized essentials will be used to accelerate nursing's move in the direction of competency-based education, which will impact hundreds of programs accredited by the Commission on Collegiate Nursing Education and other entities. As part of this work, AACN will host a number of feedback sessions at the upcoming conferences and several regional meetings over the next 6 months to make sure that we hear from all of our communities of interest. We're casting a wide net as we work toward building consensus around how best to prepare the future nursing workforce. A key component of this data collection and public comment period is this National Faculty Meeting. AACN developed this mechanism to encourage feedback on the essentials at the local level to ensure that we hear from all types of nursing schools, large and small, public and private, liberal arts, and research-focused intensive, to make certain that the essentials are broad enough to address the needs of our diverse membership. To facilitate this dialogue you are about to have with your colleagues, we've developed a video featuring members of the Essential Task Force who will walk you through their work to identify a conceptual model with 10 domains that are used to provide structure to the new essentials. Other materials provided to you include some background references, a PowerPoint presentation from the most recent AACN Essentials update, and discussion questions designed to spark robust conversations. We have also provided a link to a survey that will capture your input from your meeting, which will help us identify recurring themes, content gaps, and suggested edits. I wish to thank you for bringing your faculty together to help us think differently about how to educate the future nurses for professional practice. We are a community of leaders, and AACN needs to hear from all voices to ensure that the development of the new essentials is on target, comprehensive, and forward-focused. Thank you and enjoy your meeting.
Through this video, we will provide you with a brief update on the work of the Essentials Task Force. The goal is to introduce the work to date, explain the process being used, and share the rationale driving the work. This will give our academic and practice colleagues a way to share in the development as it progresses to a final product. In 2018, AACN formed a task force to re-envision, not simply revise, AACN Essentials, incorporating recommendations from AACN's Vision for Academic Nursing White Paper. The task force was originally comprised of 3 work groups to reflect the 3 distinct essential documents based on degrees that you currently know. As the work began, it became clear that the group worked best as one task force comprised of 23 nurse educators and 5 practice partners, led by 3 co-chairs, 3 consultants, and supported by the AACN staff. Nursing deans serving as co-chairs: Jean Giddens, Virginia Commonwealth University; John McFadden, Barry University; Cynthia McCurran, Grand Valley State University. Consultants: Nancy DeBazio, Linda Caldwell, and Jean Bartels. Liaisons from the AACN Board of Directors, Christy Shelton, Jacksonville University, and Lynn Zahn, the University of Memphis. AACN staff, Joan Stanley, Rick Garcia, and Kathy McGuinn. This presentation will include 4 areas: background, conceptual model and framework, benefits, and next steps.
The complex nature of both higher education and nursing education presents us with unique challenges to communicate vision and strategic direction that is for the good of the whole. To come to consensus on the essentials for nursing education requires a spirit of compromise. Recalling our history provides an excellent reminder of the importance of compromise. The authors of the Declaration of Independence did not agree with everything in it. Each had their own interests, priorities, constituents to satisfy, and beliefs. It was not a matter of unity of thoughts, but the spirit of unity that compelled them to compromise. The good of the whole was the priority. Choosing to be informed, respecting diversity of thought, and giving up some of what is personally valued, while ensuring quality, future-minded direction, and integrity of the profession has driven the Essentials Task Force. Together, nurse educators and practice partners have identified our gaps in how best to deliver education and prepare for reality, and how best to foster transition to practice and retain the workforce. The task force is listening, and some exemplars will be shared. From our practice partners, we have learned a great deal. Jill Case-Worth from Wellstar Health System noted employers are not even aware that there are documents called the Essentials that could provide insight into expectations for BSN graduates, resulting in costly onboarding activities. Rachel Start from Rush Oak Park Hospital noted among graduates the lack of understanding of population health and care coordination, and lack of comfort in environments outside of acute care. Full scope of practice is needed as volumes shift to ambulatory settings. Rachel also noted the need for graduates to embrace social change as related to equity and justice. We must fix the dysfunction in healthcare to fulfill our societal contract to promote health. Additional comments from our practice partners included concern about turnover, with nurses leaving the profession unable to deal with conflict and challenge, simply not prepared for the real world. Related is the need to focus on self-care to prevent burnout. There is a growing concern for mental well-being. Susan Mullaney from the United Health Group has observed inconsistency among graduates across all degree levels and variability in length and expectations of programs. She stated, "We are not sure what your product is." In addition, if there is a difference between the ADN and BSN prepared nurse, this needs to be evident. Susan expressed concern about quality of a program. If accreditation is a measure of quality, how can there be variability in the product? Considering tuition investment expended by health systems, how can they know a good program and ensure a return on investment? Faculty partners have also shared insight to inform thinking for the Essentials document. Being silent and unknown is a persistent problem in nursing. Nurses cannot broadly articulate that which is uniquely the discipline of nursing. In an effort to meet consumer demand for RN to BSN education, often identified as quick, easy, and lower cost, have we diminished the quality of the BSN degree? And is there an impact on the profession as a result? And nursing's disciplinary knowledge must be clearly reflected in the document. This type of collective insight, along with dialogue with multiple stakeholders and an extensive review of the literature and existing practice guidelines, have led to our draft conceptual model and framework.
Now we're going to talk about the proposed framework and the model for the revised essentials. The model includes 5 components: the draft introduction and background, draft domains and domain descriptors, draft competencies, draft subcompetencies at 2 levels, and a draft conceptual model. Let's start with the introduction and background. This represents introductory information that sets the stage by providing context and purpose for the essentials. The importance of the introduction cannot be overstated. The introduction intentionally nests the discipline of nursing clearly as the foundation of the essentials. Put another way, there is a need and a desire for nursing as a discipline to be well represented. Several elements to the introduction are noted on the slide. The next component of the essentials is domains. A domain is a sphere of knowledge or a grouping of like elements and provides the overarching structure. Competencies are placed within the domains. Domains of competence are defined as broad and distinguishable areas of competence that in the aggregate constitute a general descriptive framework for a profession. We started our work by using the interprofessional domains as proposed by Englander. These were designed to enhance consistency for the health profession's education. Since the development of those domains, healthcare in our world have changed. We also saw opportunities to better represent nursing. For this reason, the task force revised some of the domains and reframed how the competencies fit within each. So now we have a revised domain list. Some of the domains are the same, some have been revised, and some are completely new, including population health, safety and quality, information and communication technologies, and scholarship for nursing practice. In addition to domains, there are several important concepts and constructs that run across multiple domains. These are visible within the competencies and include diversity, equity, and inclusion, social justice, determinants of health, communication, ethics, policy and advocacy, and innovation, to name a few. Next, let's look at a domain and domain descriptor. This is an example of Domain 5, Safety and Quality, with the domain descriptor. There are currently 10 domains with domain descriptors. The third element of the model are competencies. Competencies are broad, measurable, observable, and they are designed to be applicable across all care settings and across all populations throughout the lifespan. The intent is that any curriculum model can be used to teach competencies and assure that the learner has achieved the competencies.
So let's take a time out and briefly discuss competencies and competency-based education. First, here's what competencies are not. They are not a checklist of tasks. They're not a once-and-done testing experience. They are not isolated experiences nor demonstrated in only one context. And they are not captured in an objective test. Competencies are a set of expectations which, when done in the collective, demonstrate learners' ability to do something with what they know. Competencies must be transferable across all spheres of care delivery. That's disease prevention and promotion of health and well-being, chronic disease care, regenerative or restorative care, and hospice, palliative, or supportive care. And competencies must be consistently observable in multiple contexts. Most importantly, however, competencies represent clear expectations made explicit to our learners, to employers, and to our public. Competencies must be visibly and objectively demonstrated in performances that are assessed in multiple contexts.
With that helpful explanation, it should be clear that competencies are used in several ways. Competencies provide guidance in how we teach and what we teach. They provide guidance in what we expect of students, and they provide a framework for performance assessment across all spheres of care and professional practice. We should expect all graduates exit their education programs with defined and observable skills, attitudes, and knowledge. Next, let's look at how competencies fit within a domain. Here's an example of Domain 5 again, Safety and Quality. You can see the domain name, descriptor, and the 3 competencies. In our draft work, there are an average of 4 to 5 competencies in each domain, but some domains have more. One of the things you should notice is that the competencies are intentionally written as short statements without a lot of qualifiers. We are often compelled to add a variety of qualifiers to ensure we have addressed every possible dimension. However, by doing that, competencies become long, cumbersome, and difficult to measure. A preface will be written for each of the domains as a blanket statement addressing these qualifiers. Because we have different levels of nursing practice, we must have a way to differentiate levels of learners and practice. Each competency will have 2 sets of sub-competencies to drill down to the specific measurable, observable evidence of competency attainment by the learner at each level. Next, let's take a look at a draft example of a competency with 2 levels of sub-competencies. Returning to Domain 5, Safety and Quality, you can see Competency 5.1 with 2 levels of sub-competencies. Collectively, these sub-competencies, Entry and Advanced, provide a picture of what nurses are expected to be able to do with what they know at each level. Again, recognizing that there are different expectations for students at different levels. You might notice that there are 5 sub-competencies for the entry professional practice learner and 7 sub-competencies for the advanced professional practice learner. The important lesson here is that the sub-competencies stand alone. In other words, they collectively describe what is needed for attainment of that competency at that level. The specific sub-competency does not directly correlate across levels, but rather builds on prior sub-competencies. So how do all these fit together? This is where our conceptual model fits in. Set aside what you know about the essentials, and set aside what you know about nursing education as I introduce the new model. We propose that we reframe the essentials away from the current perspective, that is, based on an academic degree, and instead focus the essentials in a paradigm based on competency assessment in 2 levels. Level 1 represents entry into professional practice, and Level 2 represents advanced professional practice. Students in a program leading to entry into professional practice demonstrate Level 1 core sub-competencies, as shown in the yellow box. Depending on the type of program they are in, students may also complete additional competencies, certificates, and/or badges, as shown in the green box. Level 1 is not only a focus on becoming a nurse, but gaining a strong foundation in the discipline. These sub-competencies incorporate the knowledge and values of the discipline. Nursing has its own science, and this disciplinary grounding is vital at this level. Knowledge of the discipline builds in advanced professional practice as students apply and generate nursing knowledge in their advanced roles. A student pursuing advanced professional practice completes the Level 2 core sub-competencies, which is the top yellow box, and, depending on the focus of the education, additional specialty competencies shown in the top green box. Important to note, the term advanced professional practice is broadly applied to represent multiple areas of nursing, not solely APRN education. Now, quite honestly, nursing education is a bit of a mess. We know that our practice partners don't know what our product is. The multiple degree paths confuse our patients, employers, and even nurses within our profession. We propose that the primary focus is with the competencies, whereas the degrees are secondary. In this future perspective, a graduate maintains a validated record of competencies they have achieved as a method of communicating their professional education. The assignment of academic degrees might fall into a paradigm as shown on this slide. Keep in mind, because of our multiple and messy academic paths, there will need to be plenty of future discussions to best align our current reality to this new model. Students new to the discipline of nursing as either a new nurse or coming back to school in an RN to baccalaureate program complete or demonstrate Level 1 core subcompetencies as a central element of baccalaureate education. Some programs may offer entry-level master's degrees. A student in a master's entry program will complete Level 1 core subcompetencies, and they will also likely complete other badges, a certificate, or other competencies along with additional academic credits. Advanced professional practice, or Level 2 core subcompetencies, build on Level 1 subcompetencies and support master's and doctoral education. In other words, students enrolled in a program focusing on advanced professional practice competencies will have first demonstrated Level 1 subcompetencies. The Level 2 subcompetencies, along with specialty competencies established by specialty professional nursing organizations, lead to a master's or practice doctorate. A generalist master's degree would be associated with the completion of Level 2 core subcompetencies and may or may not include additional expectations for a badge or certification. Future certification requirements set at the DNP degree will likely drive the shift to the practice doctorate. There are many questions that still need to be worked out. This model supports AACN's commitment to academic progression, fostering articulation agreements and/or concurrent enrollment between community colleges and baccalaureate granting institutions. Such collaborations will need to discuss the best way to adapt to this model. But the achievement of competencies must be consistently measured and widely understood. This is what we should lead with. We have an opportunity to gain clarity through a focus on competencies and linked appropriately with the academic degree attainment. Programs will grapple with the number of academic credits students will be required to complete and what degree will be awarded. These questions are likely to unfold in the years to come.
The proposed evolving framework and conceptual model is our intentional response to concerns we heard, including variability in program length, scope, expectations, and quality of degree programs. Entrenched in a model of learning that requires validation of competencies, observable and measurable, graduates will be able to articulate that which is uniquely nursing and differentiate their level of practice. Another practice partner on the task force is Marge Wiggins from Maine Medical Center. She noted the domains, competencies, and subcompetencies developed in partnership with practice partners proves a strong basis for the practice of a new graduate. The clarity and consistency of undergraduate nursing education provides a foundation to build upon as they transition to practice. Such a model will facilitate a more stable population of new nurses, more likely to adapt to and stay in nursing in today's highly complex healthcare system. Dr. Wiggins summarized the benefits with the statement, "This is a bold step for nursing, but years from now, there will be a sense of appreciation. Nursing was advanced by planning for the future through advancing education. Time will show we will be an even stronger profession for the people we serve."
At this point, you may be asking, so what's next? When do we get the final product? How will this affect my program? How will this impact my next accreditation visit? Some of you may be in the middle of a curriculum revision. Should you stop and wait, or should you continue? We ask you to keep in mind, our discipline is comprehensive and varied. We have had to do some deep dives and then dwell in a broad range of topics. The time we are taking reflects our intention to produce substantive drafts of material that you and all of our stakeholders can use to provide feedback. And we will use that feedback to revise and refine the materials. The draft materials are in varying stages of development. The draft domains and descriptors are available to you now on the AACN website. This document has had several evolutions based on the feedback we have received. There are other documents currently in formation and not quite ready for review and input. For example, the competency statements that accompany each domain and the 2 levels of sub-competencies for each of these competency statements. The task force will continue writing these through the winter, and we will be sharing them with you for input. I think you're getting a grasp of the magnitude of the work we are undertaking. We are implementing our plan for presenting and receiving feedback from a large swath of stakeholders. This national faculty meeting is one such venue. Please also consider attending upcoming AACN conferences that include sessions on the essentials, or perhaps one of our upcoming regional meetings or webinars. As we get feedback, we will continue to re-envision our drafts. I think you're seeing how this is an iterative, zigzag process of writing, getting feedback, and rewriting.
You may be wondering about CCNE accreditation. Once the AACN membership approves the new document, it will be reviewed by CCNE. The current CCNE standards for accreditation of baccalaureate and graduate nursing programs 2018 went into effect on January 1, 2019 and requires the current essentials documents. The next regular review of accreditation standards is scheduled to begin in 2022. However, the CCNE board may decide that an earlier review is necessary, depending upon when the final essentials document is approved by the AACN membership. The review and potential approval may take somewhere between 1.5 and 2 years. In the meantime, programs hosting a CCNE on-site evaluation or submitting a report to CCNE should plan to continue to address the current essentials documents.
Additional items we are working on include the creation of a glossary, examples of learning activities and assessments for the competencies, ensuring adequate clinical and simulation experiences, and how our work informs the DNP projects. We will continue to dialogue and garner feedback from other professional nursing associations, including CCNE, the American Organization of Nursing Leadership, the American Nursing Association, and many other specialty nursing organizations. We know the work of our task force is not the end of the journey for the domains, the competencies and sub-competencies, or competency-based nursing education. Toolkits need to be created, faculty development opportunities need to be identified, and a plan for broad dissemination to all of our stakeholders still needs to occur. Many dedicated and enthusiastic experts are contributing to this project. We are grateful to our task force members and all of you who have taken time to provide us with ideas and suggestions. We will not forget the contributions of our former task force member and dear friend, Dr. Ann Thomas, who recently passed away and continues to inspire our work. We hope this brief introduction provided you with a grounding in our work and where we are moving. Our work is dynamic and will continue to evolve. We look forward to your input, feedback, and future discussions.